Welcome back, project people. Hope you're all doing really well on this lovely Monday morning, or whichever day you're listening to this. Today's episode is with Nikki Manvell, who is a weapon physio here in Newcastle, and the whole conversation, this will be part one, is on proximal hamstring... Far out. Proximal hamstring tendinopathy. Yeah.
Or just proximal hamstring tendons.
Tendons
really.
in general. Yeah, great to get away from the foot and the ankle and the knee.
I really enjoyed this conversation today. Well, it wasn't today.
Yeah, it was great. I mean, we always talk about the knee, the foot and the ankle. We haven't had anyone upper limb yet, so we're getting closer. We're on the hamstring, and then I reckon hip next. We've got Mick Hughes. We talked to him about ACLs. That'll be out soon. But today's episode, is with Nikki. But like we did a couple of weeks ago, we're going to do a bit of a race recap from today. What did we do today?
Blackmores half marathon.
Oh, actually, no. Before we get into that, highs and lows.
Highs and lows of the week.
Yeah.
Wait, first I just wanted to say I'm impressed that Project People has actually stuck and you still have said it again 2 times now.
Right? And I wanted something that just rolls off the tongue.
I'm just surprised. Like, you know when you're like, yeah, I'm going to start saying that and it never actually, you never actually do? Well,
what was another stupid thing I was saying? Rock stars, legends. I said legends way too much. That's what I was saying previously, but now Project People. We'll see if it sticks.
Snakes.
Mad Snakes. That was the other one that we talked about.
That stuck on for a while.
Yeah. It stuck with me, but not with anyone else.
I like Mad Snakes. I think I started saying it a bit. It's quite funny.
That's funny.
Highs and lows. So my high is that I got a PB today. Definitely wasn't expecting it. Wasn't really planning on it.
Yeah, did well. Killed it.
Yes. Felt good, actually. It was a really good run.
In the half marathon?
In the half marathon.
Yeah.
Yep. I didn't think I was going to PB because we'll talk about that later. My low was that, again, another reason why I didn't think I was going to PB. I just had really bad sleep this whole week.
Yeah, you were horrible.
Just tossing, turning, couldn't get to sleep, just
one night you went to sleep at like 2 a.m, hey?
Yeah, just so annoying when that happens.
Yeah.
I don't know, I feel like I'm not stressed. Like, I don't feel stressed.
Yeah, sleep's the one thing. You've got to get that right. You've got to. I think that is the
happened
single...
2 nights in a row. I was getting grumpy.
Single most important thing, I think, of all the things and factors that contribute to like injury, performance, and that's why I think it's so. Like I ask my patients about sleep. I think it's so important.
It's such a vicious cycle too. Like when you don't sleep, you don't eat well, you don't train well, you don't communicate well, you don't. There's so many things. Well, that's me, anyways.
Yeah.
I feel like that's like the thing that makes my world go round.
Yeah. Any other highs? Any other lows? You were sick this week.
I was sick as well. I actually do think that was hay fever though.
Yeah. That was another reason, because we were talking about that you didn't think you were going to PB.
And yeah, so sick.
But still did it.
Sleep didn't go well. Didn't feel like I'd really put in like dedicated training sessions towards this run. Had just been running like a lot, but not really structured training. And then also got hit by a car a couple of weeks ago, which knocked me around a bit too.
Yeah. It is true what Michael Nitschke said. You just got to spend time on feet. Well, he was saying that for the marathon, but I'm sure it's for all that long distance endurance running. Yeah.
What were your highs and lows?
Highs and lows. A big high was us running together for the race. That was really, really fun. Even though you were just blitzing it down those hills. My knees, my God. I thought I was going to do my ACL down some of those hills. You were at least 10-15 seconds. Luckily,
race strategy was I just came up with it on the spot. I was like, I'm just going to fly down these hills.
Yeah, but I've got to admit, you're an absolute loaf up the hills. That's where I knew I'd go.
I'm a loaf. That's a good way to explain it.
But yeah. Other high this week, patient clinic wise, I had a day. I don't know what day it was. It was Thursday afternoon. I had maybe 4 or 5 patients that I completely discharged, or am seeing them in 6 months. That was a really nice high. It's great. It's always good to say goodbye to people because they're either at 95% or they can self-manage, or you're reviewing something later on. That was always good, and it was like in a row. I remember walking out and I was saying to admin, I was like, man, I'm just not seeing them anymore, which is great, which is really, really good. And not often you get them in a row like that, which was good. Low this week, you made me sick. Well, you said you had hay fever.
Yeah, true. Maybe it wasn't hay fever.
Yeah, so I got a little bit sick. Other low? Actually, yeah. Thursday night, so I had my scheduled run was a kilometre warm-up, 8 miles, or I don't know. No, sorry. A kilometre warm up, 10 kilometres at marathon pace, a kilometre cool down. And it was like raining and wet, and I didn't have any other time I could get it done. So I was like, I've got to get it done. And I was like running into the wind and the rain, and it was just horrible.
But you run so fast.
Yeah, but I stopped and got a drink, and it wasn't 10K.
I'm surprised the watch didn't make it into your highs.
Oh, yeah, got the Garmin Forerunner. That is a big high. But I kind of got that towards the end of the week. I'm still on the edge. It is a good watch.
You're not sold on it yet?
Not sold on it yet.
Really?
I do like, and that was actually a bit of a...
I think you'll do, once you do a track session, I reckon you'll be sold on it.
Yeah, that was a bit of a low on the run. I couldn't change my music, which is a real third world problem. Like, I couldn't change the music on my watch, but I did have a couple of good songs. But yeah, it was a good week. Today was fun. And let's get stuck in. What do you think about the race? Run us through your race plan, because you weren't going to PB.
I think that maybe that's why I PB, because usually I get really like stressed. Well, not stressed, but like I won't sleep well the night before because I'm like thinking about it, and then I don't know.
So that was your
hyped
plan.
up. I didn't think I was gonna run a PB. I was like quite happy to just. Plus, it was hilly. It was like 200 and something meters of elevation, which I suck. As you said, I'm a loaf up the hills. But I flew down them.
Yeah, you
Fanged
did.
it down
well, you
them,
PB'd.
actually.
It was a great run. That's one of the most... That's the best. I haven't done that many runs, but that's the most iconic, scenic run I've ever seen.
I loved it. Like, it was very twisty-turny, but I think that helped me personally a lot. I think a lot of people would say otherwise, but it just made me... I don't know, I felt like I was just concentrating on the run and the scenery and everything. It made it go quicker.
Over the bridge. When you come around that 2K... Oh, actually, no. I got the biggest high. I should have wrote this down. The biggest high today of this week. Sorry, second biggest high. Us doing the run together was fun. Getting a picture with the winner of the female. I can't remember her name. So Kelly and I, we went and watched the presentation of the male winners and the female winners. And the female winner, she was just incredible. Her running, she was incredible.
And the male, they were both incredible.
Yeah.
The male he did the fastest marathon on Australian soil.
True. But
it was great conditions today too.
Yeah,
just a beautiful
and she
day.
was so lovely. I
feel like she was pissed. She was like, okay,
well,
fine,
her
I'll have a
coach,
photo
manager,
with you.
whoever was like, I was like, can I please get a photo? Because I wasn't going to do it because I felt bad. And then you were just like, oh, fuck it, just go up and do it. Who cares? They probably get asked all the time. And I was like, I really want to get a photo with this incredible woman. And then the manager's like, yeah, you're sweet. And then we got in the photo and she did not look. And I was standing half a meter away. I didn't want to get close to her and bump her, or I just...
Fair enough though. She just ran a hectic marathon.
Yeah, I felt real awkward. And the photo looked awkward, but I don't care. She was awesome. And she looked fine. She was just so casual. Yeah, and you and I have just run the half and we're about to die. It's incredible. But what else about the run did you love?
Okay, the thing that I didn't like, let's say that, is that we knew so many people running today and I didn't see anyone on course. I think because it was so twisty-turny, it wasn't like Gold Coast where you could just wave to everyone along the way. Yeah. So I didn't love that, but it was a beautiful day. Could run down, we stayed very close to the start line as well, so I didn't have to park and worry about that, so that was good. That made a big difference, actually.
Yeah, you're right on that topic. One thing I love about the races is when you see the elite come back. Yeah. It's really fun to see them out on the course. And we were saying on the marathon, I was like, it's crazy to think that we run on the same courses as elite males.
But they were so... But I also just loved... we just knew so many people racing today, so it was just such good energy.
Congrats to everyone. There was a couple of big milestones.
Nikki, we better give
Nikki on this episode, she ran her first marathon and absolutely killed it.
Yeah, so we were talking about her hammy having been a bit of a pest over the last little while and held through. Hammy was no problems at all during her marathon. Yeah. She did 3 hours and 55 minutes, I think.
Yeah.
And
who else?
Her ITB was a bit sore at the end.
Yeah.
Walking with a bit of a peg leg, but that's okay.
You would expect that.
She killed it. The other winner, the winner, we think she won, Regina Wright, she won the women's Australian Marathon Championships today. Incredible. She is incredible as well. That was so cool watching her cross the line. You could just tell that she put in such a good effort, and we were, tracking everyone along the way.
Just a huge title. That's a big race and a big win. That's incredible.
Yeah. And it's such 2 hour. Wait, what did she do? 2 hours and 47 minutes. That's crazy.
That's wild.
So fast.
That's what. Yeah,
So
it's incredible.
impressive.
And she's got really cool shoes. They're like these tiger printed shoes.
I didn't see.
Yeah,
What brand?
I think they're maybe the Alpha Fly. I don't know.
Oh, okay.
I saw so many good shoes. That was a high, actually. How good is
Seen
it?
the
How
shoes.
good is it when you hear the like the vape? And then it's not obviously the vape, but it's the foam, and you just go, "This is who said?"
Everyone had vapes on today.
Yeah, Jody was saying that,
Could
and
you
he
hear
did
them
really.
slapping?
Yeah, he
Yeah,
said the
Jody
slapping
did well.
puts him off, but
He had the Ons Cloud Monsters.
Yeah, that was really good. Racing is really, really fun.
So
It's great.
fun. We
And
had a great
all
day.
the icons, that was awesome. I would love, I'll definitely do that again next year.
Mara next year?
Yeah, I think so. Yeah, it was good.
You
It was
reckon?
really fun. But I got to admit, the gels did get me. I only have one gel.
Oh, yeah, you
And-
had a bit of runner's guts.
Yeah.
Need to go back to
nearly
Kelsey's podcast.
Yeah, I nearly pulled out at 14K to go to the bathroom. Remember that's when I dropped real far back and I was looking for the bathroom. I was like, all right, sweet. If I go to the bathroom for a minute, I've just got to run 15 seconds per K quicker than you for 5K to catch back up to you. And then I just said to myself, I said to my brain, I just remember running going, nah, there's no way. I'm just like tensing every muscle going, there's nothing. I'm not even going to lose a bit of sweat, nothing coming out of my body. I know, it was sweet.
You just got to make it pass, I reckon.
You
Like
do.
there's that sensation is there and you've just got to get
It sucks
past
though.
it and then you're good.
Yeah.
Yeah.
Oh, Vlad and Ben, they did really well.
Yeah,
Incredible.
Vlad smashed
Yeah,
it.
Vlad, I think, got 11th overall. I think maybe.
Something like that.
Yeah.
Very fast. 2 hours, 20 something
Yeah, congratulations
minutes, I
to
think,
everyone.
or 30 something minutes.
Yeah, just incredible.
Yeah.
The thing I took away from all of that is just people really love to run for these races. You're so happy coming over the line. Like, people were crying. Like, that's just incredible. It only made us
such
cry.
a great accomplishment.
Yeah,
For
it was
sure.
really, really good. Alrighty, guys, that's it from us. But please enjoy part 1 with Nikki Manvell.
Yes, and congratulations on your amazing marathon today, Nikki. That was incredible. We were so impressed.
Yeah, awesome. See you later, guys.
Welcome back to another episode of the Sports Medicine Project. Thank you all for joining us again today. We have Nikki Manvell here with us. Thanks for joining us.
Thanks for having me.
Yeah, how you going, Nikki? Good?
Yeah, I'm really good.
Really excited for today?
I'm really excited. The anticipation's been building for a while now.
We've been talking about this for a while.
We have been.
Yeah, it's going to be good. And it's going to be nice to talk about something other than feet and ankles.
Yeah.
We haven't
And-
talked about hamstrings, hips too much.
All being in the one room. Usually we do this on Zoom.
Yeah, that's true.
This is the first in-person podcast I think we've done.
Well, what a pleasure.
Yeah, very exciting. Now, we apologise. The audio should be good. We've got a 3-way mic. We've all got headphones in, so it should be okay. But if not, we'll tweak it a little bit. But bear with us. Should be okay.
So Nikki is an APA titled musculoskeletal physiotherapist. So Nikki, you've done your masters, that's right?
I have, yes. I've done my masters in Masters of Manual Therapy. through
Interesting.
UWA Perth.
Yep.
It's changed a fair bit since then. So even though it's called Masters of Manual Therapy, it's not what it sounds like, I suppose, or not what the title says.
What was it? Like, what did it mainly involve?
Just like more modern, what you'd assume a master's course would have in it. So a lot more clinical reasoning, high level thinking, lots of placements where we got grilled a lot about our clinical reasoning process and just a higher level of what we did at university in the musculoskeletal courses.
Yeah.
Is it now called musculoskeletal physio, or do they still call it
It's
manual
not.
therapy?
No, it's not being run anymore. Not through UWA. So I was the last cohort to go through. Unfortunately, it was a really good course, but
Yeah, wow.
they closed it down.
So you're a sports physio.
Musculoskeletal.
Sorry, musculoskeletal physio. And then what, because there's specialist, is there a sports physio?
Yep.
And they all just go down different routes or a specialty, is that right?
Yeah, so the APA has titling pathways now where you can become a specialist in certain fields. So sports is one and musculoskeletal is another.
Yeah.
There's different pathways that do a little bit of combined, so you can do a little bit of both. And there's certainly sports within the musculoskeletal setting. In the master's course I did, they had a lot of sports people come and teach us.
Yeah, that's good. How long have you been qualified? Not qualified, with the extra title?
So I got titled in 2015.
Oh, that sounds like cool, like you're a doctor.
And how long have you been a physio for?
Since 2012. So I was pretty early on to go do my masters. I was the youngest in my cohort.
Yeah.
And I'm always a big advocate for trying to upskill yourself and learn as much as you can, as quick as you can.
Yeah.
I spoke to a lot of colleagues heading into doing my master's, and they all said, wait until you get a lot more clinical experience before going down a master's pathway. But I found it heaps more beneficial to get more knowledge earlier so that I wasn't missing things, because you don't know what you don't know. So my approach was to try and get as much knowledge as I could as quick as I could.
That's interesting.
Yeah. And where did you do your undergrad? Newcastle?
Yep. So I graduated from Newcastle in 2011.
Yes. Nice.
And then feel like I haven't really left.
Novocastrian through and through.
Yeah. So I did my 4th year placement with Nikki. So that's when we first met, I think.
Yes.
And then triathlon sort of brought us back together.
It did, yes.
Yeah, found your way home.
I got to the pub that night. I was like, you want to come and do the Ironman with me? And you're like, maybe.
Twist my arm.
So, and that was at New Moves.
Yeah, so I have 2 clinical roles. So 3 days a week I work at New Moves Physiotherapy, which is the on-site clinic at the university. So it's upstairs at the Forum. So I have access to this amazing gym facilities and fields and the pool and basketball courts and all sorts of things, and treating a demographic of reasonably health literate, highly educated, highly motivated, fitness type people playing sports and going to the gym. So that's a dream cohort of patients to treat. And then the other 2 days a week I work at Newcastle Sports Medicine with a couple of sports doctors, so Dr. Ross Cairns and Ewan Bradbury, who's the sports med reg out there. That's at Warners Bay, so that's a bit of a different kind of role, because it's more of a like consulting using rooms, so there's no sort of big gym set up or ability to do high level rehab out there, but it's more diagnostic, I suppose, in some ways.
Yeah. And do you see anything specific? I mean, obviously you'd be seeing a lot of things head to toe, obviously not feet. But
keep that to the professionals.
Yeah, keep that to the podiatrist. But you see, what do you say would you see the most body part, I guess?
I see a lot of tendons, but definitely with Ross, I don't know how, but I've developed this reputation for being the proximal hamstring guru out there. Yeah. So that's what brought me to talk to this topic today. I like to treat knees, so I see myself as more of a ACL knee rehab expert, and then a contact shoulder expert, I suppose. So I treat a lot of rugby athletes and see a lot of contact-based shoulder injuries, and I feel like that they're probably the 2 areas that I have the most knowledge in, but have definitely picked up more knowledge in the proximal hamstring tendon. And I think relatively everyone sort of thinks they do an okay job of the shoulder and the knee. I think the proximal hamstring tendon's probably not done so well. Yeah,
it's similar with the Achilles. Hey, I know Kelly, and you're going to say that you've had basically a pretty significant injury around 14 years ago.
Long time ago.
Long time ago. Kelly, you've had yours since I've known you. They seem to be people sustain them and then somewhat get better, but they really seem to linger around.
They're a big pain in the ass. They hang around for a long time. Yeah. And I think that's a huge part of managing patient expectations when they come and see you when they have one of these injuries. It's a lot of it is about setting up realistic expectations that this is probably going to be hanging around for a while, or if it does go, it may come back and you may have to manage it. Yeah.
So tell us your story. What's been your hamstring journey?
My personal hamstring journey. So back in 2008, I moved to Newcastle to come to uni, and I signed up to play for the mighty Seahorse, University Rugby Club.
Nice.
And I stepped over a ruck playing, and Willie Mason's sister jumped on my back, and I did the splits. And I headbutted myself in the knee, and I felt something pop in my hip. And I thought at the time, because I was only a first year physio student, at the time it felt like I had dislocated my hip, and so I was rolling around the ground swearing and crying, and they called an ambulance, and I got stretchered off the field and green whistled and took me to hospital, x-rayed it, it was all normal, and they just said, your hip's in, you're fine. The hip's in, here's some crutches, you'll be right.
Which is this common, you're a rugby physio, does this happen at the hospital? Do they, if you're not dying, they just check the main things, not fractured or dying, leave, basically?
That's what I say to patients and people. Hospital's a really good spot to go if you're dying, but if you're not dying, it's probably not the best place to go.
I think they attempt, Josh, my husband's an orthopaedic registrar, and they attempt to set up systems to catch the more sinister soft tissue injuries, and they try and refer to follow them up. And
it makes sense. It does make sense. You can't obviously see every single thing that comes in. Like the hospital will just be overrun. But anyway, sorry to cut you off.
No, that's fine.
Sorry.
So I discharged to community, first year physio student, knew nothing. Bedbound for a couple of days, couldn't get out. Like my hamstring was just black and blue and swollen and awful. And I didn't see anyone about it. So I don't know how. What
were you thinking? You were physio and hadn't done that lecture.
I literally remember going to a lab and we were doing gait analysis, and they used me as a patient to demonstrate how someone who's injured walks with crutches. But no one ever said what's wrong, what happened, and let's assess it.
Did any supervisor or anything come and see me on the side?
Anyway, it's madness. But at the time I don't know what happened. But then time passed, and then I got back and I played the rest of the season.
Wow.
And then I just forgot all about it.
Yeah.
Forgot all about it. And then years later started running, and I was like, my hamstring, I had this pain, and it come back, and it would just come in waves. Whenever I'd ramp up my running volume, it would come back.
Yeah.
And then haven't heard from it for years, and then on and off, whenever I'd ramp my running volume, it comes back. And then now it's at the forefront of my mind because I'm marathon training at the moment.
And you're marathon
next weekend.
Yeah. Actually, when this comes out, it'll be the weekend just prior. It'll be next week.
Next week, yeah.
Wow. So, over that time, was it, other than when you were running, did you have any experiences, when did it talk to you? Is it when you're sitting, or general day-to-day you're okay, but there's certain times where you're like, I ruptured that not long ago?
I would definitely feel it. Classic things, I'd feel it. If we're doing body balance class or something, and I'd be stretching, I'd be like, I feel that pulling on that side more than this side. Or I'd sit on a hard chair for a long time, and I'd find myself shifting off my butt cheek, being that hurts. And then it wasn't until when you finish physio, you're like, that probably was a rupture. But I can't believe I didn't do anything about that. And then seeing them over the years, when you see that patient come in and you tell them your story, I'm like, I think I had one of these injuries, but I didn't do anything about it, and I'm okay, sort of thing. Yeah. So I don't know, it's interesting.
Yeah. Do they reattach when they rupture? Can they reattach?
Yeah, they form a neotendon, it depends on the amount of retraction. So there's different classifications of different types of ruptures and the amount that they retract and how many tendons are involved, and that often dictates whether or not you go down that surgical pathway or not. So David Wood's done a good classification of that. So there's different classes from category 1 to category 5, and basically the further down that continuum you go, the more likely you're going to need to have it reattached. Otherwise it just sort of tethers itself halfway down your leg and attaches onto your sciatic nerve, and it doesn't really reattach up onto your ischial tuberosity.
Yeah.
Interesting. And then, I remember when I first met you, I think I had a niggling hamstring issue then. So it's common during our runs now. It's something that
we always talk about.
We're always talking about it.
5Ks in, I'm like, how's your hemi? You're like, yeah, good. Yours? I'm like, yeah, it's not too bad.
And then we'll be having breakfast later that day, and I'm texting Nikki. I'm like, how's the sitting going during your breakfast this morning? I'm struggling.
I'm slumped, sitting way back on my sacrum. It is.
What can you run us through the quick anatomy of the hamstring?
Yeah, so the thing that is poorly understood with hamstring tendon management is the anatomy. And I think a lot of people try to apply the research on tendons throughout the body to the hamstring. And the hamstring anatomy is a fair bit different to other tendons.
Yeah.
So essentially the hamstring tendons are long and they wrap around the ischial tuberosity. So looking from the back, the conjoint tendons, so the biceps femoris and the semitendinosus sort of fuse together, and they sit more on the medial side of the tuberosity, and then on the anterolateral side of that, so going more forward, more at the front of the ischial tuberosity, is your semimembranosus. And it's really, really long. So it's probably the free tendon of semimembranosus is 10 to 12 centimetres long. And so when you go into any amount of hip flexion, so it's the thickest and the biggest and longest free tendon, as soon as you go into flexion, the tendons at the back, so the conjoint tendon, pretty much squishes up against semimembranosus's insertion, and it creates like an insertional tendinopathy, not too dissimilar to what happens on the Achilles.
Yeah.
So in some ways, we talk about what contributes to tendinopathies coming back and being difficult to treat, and you see it all the time with certain foot types potentially prolonging the recovery of a certain tendon problem. This is one of those things. So like a Haglund's deformity, it doesn't necessarily cause an Achilles issue.
It exacerbates it.
It exacerbates it, and it might mean that it lasts longer because you can't remove that compressive component as easily. And it's the same with the hamstring. So because they have this, the tendons travel such a large distance right around the ischial tuberosity, right onto the back, and because semimembranosus makes up this huge fat portion that sits underneath and it gets squished from behind, it just makes it really hard to rehab it and recover from it if people are doing things that involve high amounts of hip flexion or high amounts of sitting volume where they're compressing it all the time. So it creates this little perfect storm where it just doesn't get any better.
Or what do you think that there is often elements of greater degrees of hip flexion, or like what about the speed component? Do you think that is less relevant in hamstring tendons?
No, I think the speed component is definitely relevant. I don't know whether the speed component is specific to hamstring tendons or just tendons. I think the speed component has a lot to do with the decelerating tibia, probably not so much the hip flexion compressive component. I think that's what's relevant in that example. But the other thing they talk about with hamstring tendinopathy a little bit in the literature, like they talk about intersection syndrome of the de Quervain's tendons over the radius. There's a similar thing that might be happening at the hamstring. So you have this long semimembranosus tendon, and it actually, because it's sitting anterolaterally, and then it comes down and then cuts across to the medial side to go down the medial side of your leg. And then biceps femoris starting slightly laterally comes down and then cuts to the lateral side. So you almost have this like crossing over of the tendons that happen at the back of the thigh or the high buttock. And then that might create like a little bit of a frictioning type thing as well. So you not only have the compression and the tensile loadings happening high up, but you also have this little frictioning type thing that happens as well.
Is it usually the semimembranosus that's involved, or can it be all of them, or any? Is there a specific tendon that's usually the problem?
It can be any or all of them. Most of the time it's semimembranosus. Most of the time. And it tends to be the one that has, so when they, in some of the surgical cases and surgical papers that they talk about, the proximal hamstring tendon, and when they go in and operate on it, when they inspect it, semimembranosus is the one that is the ugliest and the thickest, and it's the one that tethers onto your sciatic nerve. So it's the one they think is causing the majority of people's discomfort. And when they do surgery on it, not that it's highly recommended, but for a tendinopathy, not a rupture, for a tendinopathy, if I assume in the high level athlete, high level sprinter who's got a really nasty tendinopathy that's not responding, that would be the only reason you'd have surgery on it, I would assume. But the surgery is quite crazy. Like they cut they do a tenotomy, so they cut the whole semimembranosus tendon off, and then they suture it to your biceps femoris. So they say, all right, we'll just remove that complete compressive force, take it off and attach it further,
kind of what they do
back.
with like the long head of biceps.
Correct. Yeah. So they're also doing like a tenodesis, like pulling it down and plugging it somewhere else.
Do you think, like, from a new graduate and student point of view, because I remember in podiatry we do learn all the way up to the hip, I was just under the impression it just inserts onto the ischial tuberosity. Yeah. Like, do you think people have an understanding of the complexity of the anatomy?
I don't think so, because I didn't. When I left uni, obviously I'm a bit stupid, but I ruptured my own hamstring. I didn't even know about it, but I don't think you do. I think it's, and even, if you look up a textbook now and you go to just learn about the complex anatomy of the hamstring, it's not in there. It just says hamstring tendon, attaches onto the ischial tuberosity. You don't learn about, you almost think that all three tendons just form a big fat tendon and that's it. And it just pokes on there, but when you start digging deeper into it, you're like, holy crap. And there's heaps of variations.
Does it matter for management? Like, how does that change your management, having that knowledge?
Well, there's a lot of papers out there that look at what tendons are active during what type of
Phases
hamstring
of gait and
loading.
things like
Yeah,
that,
and exercises. So they'll say, oh, a deadlift activates this versus a glute ham raise activates that versus a Nordic does this and a hamstring curl does that. And so having a slightly greater understanding in the assessment process of which component of the hamstring you think might be more involved might guide what types of exercises you choose in your rehab. So if you're thinking it's more of a semimembranosus issue or a biceps femoris issue, you can tailor your rehab a little bit more towards that. Now, I don't know 100% whether the knowledge of the anatomy gives you that information or whether just a targeted assessment gives you that information. So similar to, you know, and the same with all tendons. Like if you really understand the rotator cuff in its depth, you can target certain things in your assessment that then guide your treatment. But also just really doing a super targeted assessment guides your treatment.
Yeah, so, like everything should either move you closer or further away from a diagnosis.
Yeah, and it helps, you know, if you know that someone's weak or has a lot of pain in a particular position, you know that maybe you don't start them there, but that's where you want to go eventually. Yeah.
Reverse engineer it.
100%.
Nice.
Yeah.
So classical presentation, someone comes in, what would you see as the most common way it presents to you in the clinic, and then, you know, if there are any special tests or ways that you kind of rule things in and rule things out?
Yeah, so the classic case would be, we're talking tendinopathy. So classic tendinopathy, high hamstring tendinopathy is usually a runner or someone who's recently taken up running.
Running, fucking injuries with running, I'm tired.
Runners.
Yeah.
I think the issue with running is it's so addictive and people get so good at it so quickly that they overload themselves too fast. Like, you know, if it was just a sport and they were playing it once a week and training twice a week, it probably wouldn't be a massive issue.
It's such a low barrier to entry. You got a pair. You need some vapor flies and some running gear.
100%.
Only vapor
flies.
Three
pairs of
vapes. And you're good to go.
3 pairs of vapes and you're good.
$1,000 outlay.
Yeah. So I think, classic cases, a runner, recreational runner, hasn't run much, spiking volume of running, and away you go. But you also see it, you know, obviously sprinters, hockey players, people who have to bend over and, you know, hurtlers and things.
Hurtlers I always look at hurtlers, I'm like, man, you must have a robust hamstring tendon.
Blows my mind. Like, I think, how did your hamstring still attached?
Yeah, I know.
That's not ruptured. Because is it
and
not...
then you also, the other person that I see a lot of working in a gym setting is your older woman, yoga addicted, like just my hamstrings are tight and they're just stretching them, going to town. You know, they can get their forehead on the ground, like they're so flexible.
Yeah.
They're the other demographic that I see a lot of.
Yeah, and is it usually just like, and using running as an example, is it generally just a spike in running, or is it a spike in hills, training surfaces? Is there anything odd that you see that kind of puts more load through the hamstring? Because I was under the impression it helps you accelerate and stops deceleration, but I'm sure it's probably always more than that.
Mine definitely started when I moved to Newcastle and started running up that goddamn hill.
Hills are a killer. That's mine flared after doing the Newey half, and I PB'd on the hill, like
still PB'd with a sore hamstring.
And I cooked myself on the hill running up and down straights. But hills are definitely a killer. Increased intensity sprinting is a killer. So people that start doing more interval sessions and faster paced running definitely is a killer. And that also brings you a little bit to management. So people get a little bit off-put by having a hamstring tendinopathy and they just stop. And I'm like, no, you don't have to stop. You can still jog. Like a lot of people can still get away with jogging, or they can find an upper limit of their running that they can still do. Just don't do hills and don't sprint, and a lot of people can still cope with that.
Yeah.
And then again, working at a university setting, so many people are sitting all day. So they do their park run or whatever, and then they just sit all day.
Well, they do their long run and just sit on the lounge.
Yeah, just sitting all day.
Just look at my Strava.
And then in terms of how I would assess that person, how they present, I suppose, is that classic gluteal fold pain, so it's quite localised pain.
Yeah, and full presentation, and I'll question after.
So they present with pretty localised symptoms, however it can spread. So some people get pain that goes into their butt, so they present more of like a piriformis mid-gluteal or deep gluteal syndrome type presentation. Some people present with more distal hamstring symptoms, so report a referral into their whole hammy. Rarely, but you can get symptoms below the knee as well, so you can get referral into the shin or into the calf. You can get nervy symptoms associated with it, which would be associated with those sciatic nerve tethering type presentations.
I want to talk about that more later.
Yeah, and pain with sitting, pain with stretching, pain with loading, pain with hills, pain with running fast, deadlifting type actions.
Is it pretty, and I think I'm just talking foot and ankle, I can get a pretty good idea on whether it just comes from seeing a lot of foot and ankle conditions, just from the subjective history. Is that pretty similar when dealing with proximal hamstrings?
Yeah, and I think that just looking at the body chart doesn't give you enough info, because there's so many things that can be a differential diagnosis for that body.
You read my mind. I was going to say, what do people get confused with?
Yeah,
with
and I don't know. It's hard because I see a lot of them, and they've been seeing other people or had investigations done, or and it just they often present with a bit of a cluster of symptoms, and it confuses people. So they're like, it's their SIJ, it's their lower back, it's this, it's that. But some of those classic features of, pain when running up and down a hill, pain when you're stretching the hamstring, pain when I sit on it, and you're like, that's pretty classic of a proximal hamstring tendon. Yeah, it can be lower back pain, and yeah, it can be those other things. And then when you do your physical exam, it's hard because you want to do everything, but sometimes those features are red herrings. So if I go searching around, snooping around in the hip joint and the SRJ, some of those things come back positive, and then you're left being like, holy fuck, I've done way too many things, and now I'm really confused. Is it a piriformis thing? Is it a SRJ thing? When at the end of the day, if you just hone your skills at the hamstring, you're like,
I can imagine that referred pain could be quite confusing for a lot of people, and where a lot of people misdiagnose it, because everything that you learn about tendon pain is localized. But I do often find that proximal hamstring tendinopathies sometimes aren't so localized. Can you speak a bit more to that?
Yeah, I think that a lot of the time it doesn't just present with local buttock pain. They don't just say, I've got a 20-cent piece sized pain in my gluteal fold. It does spread around. I think some of that more in the chronic cases. So the longer that's been there, the more fibrotic your semimembranosus might be, the more likely it is to be associated with some sciatic nerve tethering or something nearby.
Peripheral sensitization as well. Yeah. So you can get, I think you'll have local factors. So you may have some thickening and fibrotic changes happening nearby the sciatic nerve, which is actually mechanically irritating your sciatic nerve.
Does that run right next door?
Yeah.
Yeah, okay.
Yeah. So there's literally little spiderwebby things that can come out off your semimembranosus and sort of tether onto your sciatic nerve. So then that can create mechanical irritation. So when you
That's really noceivic, hey?
When you
sucks.
Yeah, tethers on.
That's what I picture mine.
Like grafts on and strangles the nerve.
Nikki and I often talk about when we're running, we're like, what do you think your hamstring tendon looks like? I'm like, I just imagine mine to just be wrapped around my sciatic nerve, holding on by a thread.
Well, that's what I said to Kelly. Kelly's like, hey, would you ever go get an MRI? And I was like, oh shit, no, I'm one of these.
Just look at it and cry.
I'm a catastrophizer. So if someone showed me a picture of my hamstring and it was hanging by a thread, so I would be that. I'd be like, right, I need to go have surgery. Even though I'm running a marathon next week, I'm like, it's going to snap. I need to fix it. So yes, no, I think the mechanical irritation from the physical thickness, and again, when you're moving into hip flexion, you've got the nerve sitting right next to this big fat swollen thickened fibrotic tendon that's going to squish it. But also in a acutely reactive, don't want to use the word inflamed, but you know what I mean, very reactive tendon, you may also have some chemical irritation of that nerve as well, which that can then cause aching and referral down the leg. And
so is sciatica a different? Do people get it missed or do people diagnose it as sciatica?
Sciatica's kind of an umbrella term though, anyway.
I just have patients tell me that a lot, that they've had sciatica
all the time. So sciatica is just a cluster of symptoms, I suppose. It's not a diagnosis. But all the time people come in with those sciatica-like presentations, and they might have a positive straight leg raise or a positive slump, all those sorts of things, but it's actually a proximal hamstring tendinopathy, a chronic tendinopathy that's presenting with sciatica symptoms.
Neural symptoms, think hamstring. Proximal hamstring. Within your differentials, definitely.
Yeah, well, in that,
and in I think
story.
the patient group plays a really big role.
Mm-hmm.
Yeah, with that story that comes in. So they have to have some sort of change in something. You don't just develop a proximal hamstring tendinopathy.
You guys have got it hard, because there's lots of structures in and around that area. I always joke with patients, like in the foot and the ankle, and I just go, there's not too many things here where I'm it's 5 things. It's got to be one of them. So
skin and bone just here.
Yeah, it's either skin and bone or this ligament. It has to be this. Whereas up there around the hip, there's heaps of stuff.
There's a lot of things.
Back and SIJ and all that kind of stuff.
Yeah.
When would you not be thinking, like apart from the patient group, but if you're doing an assessment, like when would you be thinking like bursitis or apophysitis or something like that?
DGS?
Could be
deep gluteal syndrome.
Oh.
Yeah, so that's your piriformis syndrome type presentation. So so when would I not think hamstring? So what are the things that would rule that in? So apophysitis is a different classification, I suppose. So it's your adolescent with the same presentation, but they're in their teen growing years. So that's different. So that's not, you manage it in a similar way. It's like load management, same as what we would manage with a Osgood-Schlatter's or a Sever's disease type case, but they present the same. So you think, oh, this is a proximal hamstring tendinopathy in a teenager, so it's apophysitis. The bursitis is a little different. So, but again, I'm a big believer in bursitis not really being an isolated cause of pain.
I imagine it would be something that would happen alongside a tendinopathy.
A lot of the time it is. So it's similar with a retrocalcaneal bursa or a infrapatellar bursa or something else. It's often in a subacromial bursa, it's often a sign that that tendon is under a certain amount of stress. So unless it's happened from an acute trauma, so if that person's fallen heavily onto their butt and it's like banged it and the bursa's blown up, maybe then their ongoing symptoms are a cause of the bursitis, and maybe you could treat that more with an anti-inflammatory and an offloading approach. But it would be similar. In the early stages, you'd be trying to avoid hip flexion and compression and those same sort of things anyway. And what was the other thing that we were talking about? Hip joint, obviously, like a Faber and a Fadir examination wouldn't necessarily
be pretty easy to rule out.
It wouldn't be really positive with that, and deep groin pain or anterior hip pain might be different, but a lot of hip OAs can present with buttock pain. So they can come in and be like, oh, my bum hurts when I sit on it, it hurts, and you think, oh, maybe that's a proximal hamstring tendon, but it's not.
No.
Yeah. So what are you doing, like from your subjective, what kind of objective weight-bearing, non-weight-bearing tests are you doing? And between each clinic as well, because obviously one clinic you've got access to a whole lot more in the gym, which is super important for any testing of tendons compared to when you're in more of a consultation where you still got access to room and you're able to hop and jump and all that kind of thing, but obviously not having the weights.
Yeah, so I think my process of examining a patient objectively, so usually I stand them up, look at their hips, get them to bend over. Most people are like, yep, there's my hamstring pain, and they can sort of point. I'm like, where do you feel that? And they're like, where?
Yeah,
pretty much. Yeah, pulls high up in their bum and they bend over. Then I don't know why I started doing this, and it might have been more of a personal experience thing, but standing then wider. So sometimes if people don't feel it toe touching,
little clinical pearl,
little
Nikki special test,
little Nikki test, is so touch your toes. Do you feel it? And if some people are like, don't feel that too much, step wide and then bend over, and some people are like, yeah, there it is, or vice versa.
Yeah.
And I don't know why that's relevant, but I think it might just capture a greater amount of the hamstring tendon being pushed in or out, or a certain amount of compression on the ischial tuberosity.
Yeah.
Then I usually look at, I clear the spine while I'm there, so I just double check that there's no radiculopathy or like a quadrant there back, and just check that it's not reproducing their hip
and
pain.
Then a quick adjustment.
Just give them a quick leg pull and be on with it. And then I usually check their slump. Usually while they're in a slump position, I might do some like hip adduction stuff, like a DGS type screening, just to check if compressing that makes it any worse in the buttock. Straight leg raise them, then like hamstring length test them. So you can do that a couple of different ways. You can do that as a straight leg raise, you can do it as a 90-90 position, or you can do a max hip flexion active knee extension type test. And then I usually add speed to that.
On that, are you just eyeballing it, or are you checking for pain at end range, pain through range? Like, what are you kind of looking for there?
Sorry, I made a really big noise. I usually eyeball range, and I compare between sides, and then I'm looking for symptom reproduction.
Yep.
So does this bring on their symptoms? If I'm just doing a hamstring length check and they're like, yeah, I feel that in my hamstring, I'm like, yeah, big whoop. And I compare it to the other side and they're like, yeah, I feel that too. I'm like, yeah, it's not diagnostic. And I'm not using hamstring length to determine if they've got a tight hamstring and then treating their hamstring tightness. I'm just looking to see if I can reproduce their tendon pain.
Yeah.
And then bend knee and then doing it
Rapidly.
fast. Yeah. To end range.
Yes, I often get them to do it actively. So I just go, extend that out. When do you feel it? Then, now do it quicker. And if they go quicker and they're like, oh, yeah, that pulls worse. Yeah. Again, that probably just confirms it a little bit more. So they're all the stretch-based tests. And in the literature, it's really frustrating, but the sensitivity specificity stuff exists around the stretch test. There's nothing on the contractile test, which is really frustrating. So it's like, but I don't stop there, obviously. I don't just do the length test and go, that's it, see ya, like you've got a hamstring tendinopathy. I then like to take some objective strength data as well. So I usually check hamstring strength in a few different positions. So I use a handheld dyno. Usually I just, as a diagnostic tool, I usually just get them to do a heel up bridge. So I sit on the bed, put their foot on my shoulder, and I check them in a couple of levers. So I bend them up at 90-90 and say, hover your other leg. Can you lift your bum up and down? Yeah. And most people go to push up and they're like, oh, that brings it on.
Is it because it's more, when you're doing that position, it's more of a compressed position? Is it?
So at that 90-90 position, you're in 90 degrees of hip flexion and you're getting the heel to dig down into the shoulder. So they can't really use their glute like a glute bridge because they can't push their foot into the bed to push them up. They're sort of digging their heel down to activate their hemi.
Yeah.
So they're in hip flexion in that position. And then I usually then lengthen the lever out, so then I slide further away, and then it's harder, not because they're in hip flexion, then it's harder because they're heavier. So I lengthen the lever out.
I really like that. I'm never going to use it, but I really like it.
So their symptom, I'm trying to elicit some symptoms with that. Yeah. And then you get a bit of a gauge of how strong they are there too. So if they're really struggling to put any pressure through your shoulder and they can't lift their bum off the bed without digging their arms into the bed, and then on the other side they pump out 5 and they're easy, you're like, oh, this person's got some weakness there, they need to catch up. Then I usually flip them and check prone hamstring curl, so at sort of 15 to 30 degrees and then up at 90.
Yeah. With the dyno still?
And then I check that with the dyno. And then if I wanted to as well in that setting, just for documentation to get an outcome measure, I check them at 90-90 on their back. So I flip them back over and I get them to dig at 90-90 into the dyno and beat them. Yeah. And then they're nice measures, left versus right, and you can get a good sweep of what, where you need to start your rehab. So some people, it's really interesting with and there's no wonder there's not much data on this in terms of sensitivity, specificity, because it's all over the shop. No two hamstrings are the same. Like I will hear someone's story and I'll be like, oh fuck, I bet you this person is weak as piss in a prone hamstring 30-degree bend. And I get them over there and they pump out 40 kilos. And I flip them on their back and they're awful. They're awful in a length test and they're fine in a strength test. And other people are really awful trying to do a bridge, and they curl really fine. So it's such a mixed bag. So is the
literature like inconclusive, or has it not been done?
It's just poor. It's just highly sensitive, not specific.
No, I don't know if it's been done. All of the stuff I've read so far, like all of the reviews on assessing their hamstring, only comment on those length tests, saying that they're the best we have. But even looking at those, I'm like, even those tests are not the best, most appropriate, like...
Do you remember what you were saying?
Yeah, so... No, you're good. So literally, if one of those length tests in that cluster of diagnostic tests is literally to stand and put your foot on a bed and lean forward. So it's like a hamstring stretch, basically. You just in a stretch.
It's so bizarre, isn't it? Because everything that we know about tendons is points towards tendon pain being reproduced by loading and speed, and why are we looking at stretching?
I know, it blows my mind. It's crazy. The only diagnostic test we have for an Achilles tendinopathy is to stretch the calf. And again, how many Achilles tendons do you see and you stretch the calf and they don't have tendon pain? So I mean, it's just madness. So, but I think that's the hard thing about hamstrings. And again, palpating them.
Nothing.
I hardly ever get pain on palpation. Like I'm digging my thumbs as hard as I can in all around the insertion, halfway down the tendon, and people are like, no, it's fine.
And it's not. They're like, that's where it is, but that doesn't hurt
to touch. Yeah, so it doesn't hurt to touch it, which is frustrating.
It speaks more to the anatomy, like you were saying. Obviously, when it's in different positions, it does reproduce the pain. Do you ever palpate in different positions?
Yeah.
Like get them in different positions?
Well, I've played around with that. I've put people in more hip flexion and dug around in it, and it doesn't. I've put them on length and I try and poke it, and it doesn't seem to hurt. So it's.
What about if you think there's like a bursitis involved?
I think that's the one. I think that is the time when it does get more sensitive to touch.
Yeah.
I have seen a case of a bursitis where I've palpated it and been like, oh, that's really tender, and the person ended up having like a big florid tendinopathy with heaps of fluid around the outside of the tendon and a big bursitis, and they responded quite well to just a cortisone. So they just cortisone in the bursa around the tendon, and it just.
When you say fluid around the outside of the tendon, like can peritendinitis happen in proximal hamstring tendons?
Yeah, I don't know if it's called. I don't know if it's the same type.
As like an Achilles,
but essentially, yeah. And I think that's that whole frictioning thing that I spoke about earlier. I think that's a similar case, and it's what's reported on MRI. So the imaging modalities. Have I finished my? I don't want to keep skipping topics, but.